Hello, and welcome to this Wound Care Today Facebook Live seminar. My name's Rebecca Elwell, and I'm the Macmillan Lymphedema Advanced Nurse Practitioner from the University Hospitals of North Midlands, based at the Royal Stoke University Hospital. I've been in post for 16 years, and as well as the lymphedema service, which sees cancer and non-cancer related lymphedema, I run the only red leg clinic in the country. I'm extremely passionate about raising awareness of lower limb conditions. Today, we're looking at venous disease, and in particular, how early intervention can prevent progression. You might ask, why is a lymphedema nurse presenting a session on venous disease? Well, the vascular and lymphatic system are very closely aligned. There's much overlap, and rarely does one condition exist without the other. Long-standing, untreated venous disease can lead to an overwhelmed lymphatic system, and thus patients develop chronic edema. So it's in my best interest and every lymphedema therapist's interest to treat patients earlier. Please feel free to join in and submit a question at any point during the presentation, and we will aim to answer as many as we can during the question and answer session at the end. Today's event is kindly supported by L&R. After this event, you can access a certificate of attendance, which you'll be able to use as part of your CPD hours for revalidation. We will share the link with you at the end of the presentation. For now, we'll move on to the prevention of venous disease progression and the importance of early intervention. So what are the learning objectives? The impact of venous leg ulcers to the NHS, to individuals, to you, your time and your own health needs, to understand what risk factors impact on the prevalence of venous disease, to understand why intervening early is so crucial, and to take hold and understand what you personally in your practice can do to promote the prevention of venous disease progression. I am a proud trustee of the British Lymphology Society. We're a group of healthcare professionals that come together to form guidelines for managing lymphedema in the UK. And we are absolutely delighted to be a coalition partner of the Legs Matter campaign. This national campaign is dedicated to raising awareness of lower limb conditions. And if you haven't already visited their website, there's loads of free resources, both for patients and healthcare professionals, to help you to manage legs and feet. From the 8th to the 12th of June, there will be a Legs Matter Awareness Week, so start thinking about what you and your team can do. Leg and foot problems are one of the biggest health challenges of our time. We need to all stand up for legs. But what's the reality of leg ulcers as far as costs? It's now known that just over 1 million patients are affected. That's 1.5% of the adult population. 42 to 47% of leg ulcers are healing at 1 year. And the annual cost to the NHS of managing leg ulcers is estimated to be £1.94 billion. The cost of treating a healed venous leg ulcer per year is around about £3,000, but this snowballs to £13,500 per year with those patients with active ulceration. The costs are astronomical, and that's without the cost to the individual themselves. So what are the factors that increase the risk of venous disease? Well, delayed intervention, that's the reason for today's session on prevention. Increasing age and comorbidities, reduced mobility and prolonged periods of inactivity, and obesity. This growing problem can have an impact on venous and lymphatic return. Lifestyle choices such as smoking, and we know that pregnancy increases the odds of developing varicose veins by up to 82%. So what proportion of patients do you see who are at risk of developing venous disease? How could you better identify them? Do you see patients post-operatively to have sutures removed? Do you see housebound patients for bloods or diabetic medication? Do you do blood pressure checks? Where are they? Could you do some leg health? Are you yourself at risk of developing venous disease? Do you complain of tired, achy, heavy legs at the end of a shift or at the end of a day? When you go on holiday, do your legs swell up after the journey or because it's hot temperatures? Don't ignore it. Think about prevention. Now we're going to go and have a look at the impact that risk factors can have on the venous system. In a healthy blood vessel, valves facilitate venous return towards the heart, thus preventing a backflow of blood. You can see that demonstrated here in the video. In a compromised system, the valves are damaged due to the risk factors. They cause a backflow of blood and expose the superficial network to higher than normal pressures. Immobility and reduced foot or calf pump efficiency also compromises blood flow. We know that 100% of fluid is removed from the extremities by the lymphatics, and this again reinforces that crossover between the venous and lymphatic systems. So what happens when the systems become compromised? We're going to look at some patient scenarios together. Patient 1, what do you see when you look closely at these legs? There's some mild hemosiderin staining. That's where the legs look brownish. Sometimes patients describe it as looking as though they've been in the sun. One leg is slightly larger than the other, showing some mild oedema. There are varicose veins, though these are mild. There's reasonable leg shape and the skin is intact. So what could you do and what would you do in practice? Patient 2. Here we can see, if we look closely, increased varicose veins. The patient is unlikely to be asymptomatic at this stage. They'll probably be complaining of aching and heaviness, maybe even soreness. There's a real tendency towards knocking the leg here. They're vulnerable. And is it only one leg? We can only see the varicose veins clearly in the photograph, but we need to think about both legs. What could you consider doing for this patient? What could you implement that may make a difference to their quality of life? And in patient 3, what do we see? We see a wound. What's our wound assessment going to be? How long would we expect this wound to heal? And what's going on with the other leg? If we're seeing a patient to treat the wound, we should not ignore the other leg. What would we do? The National Wound Care Strategy have announced today a new sequin for leg ulceration for England. This should improve the quality of care for lower limb sufferers. This is absolutely phenomenal news and very well done to Una Adderley and all involved. So these pictures show the true disease progression, increasing costs, as we've said, to the NHS, but to the individual as well, and decreasing quality of life. Patient experience is the most important. So what can you do to prevent venous disease progression? What part can you play? Well, there's lots of things that you can do to drive the prevention of disease progression. You can advocate good skin care. Patients should be encouraged to wash their legs and feet daily with a soap substitute. Dry thoroughly, especially between the digits, and then moisturise with a bland emollient. Any underlying skin conditions like athlete's foot, psoriasis or eczema should be treated promptly and appropriately, or referral to dermatology should be made in extreme cases. We can encourage a healthy lifestyle, to follow a healthy eating plan, a weight management plan in obese patients which may require referral to a bariatric service, to encourage cessation of smoking and to encourage exercise. The British Lymphology Society have a new campaign for 2020 called Everybody Can. This is about everyone moving a little more. It doesn't have to be in a leotard, but some more movement, some more exercise to encourage that muscle pump, reduce any swelling in the lower limbs and to improve venous return. Lymphedema Awareness Week will be the 2nd to the 8th of March, and we would ask as many of you to get involved and get your patients as active as possible. We need to make sure that any intervention we provide is timely but also effective. Would you wear compression hosiery if it was ill-fitting and didn't work? We can champion self-care. We can be advocates for wearing compression hosiery ourselves if we complain about tired, achy legs at the end of the day. How many of us complain that our skin is dry, especially in the winter months with the heating on? We can definitely take better care of ourselves and promote that in our patients. And we should prescribe compression hosiery where appropriate. So why compression hosiery in the prevention of disease progression in patients with venous disease? Well, there are a number of benefits to wearing compression hosiery. Compression can aid venous and lymphatic return, reducing swelling, pain and heaviness in the legs. Compression hosiery can be used for the management and prevention of venous leg ulceration. So leg ulcer hosiery kits are now first-line management in venous leg ulcers, where there is no heavy exudate and where there is good shape. Compression hosiery can prevent further deterioration of varicosities and also minimise our risk of deep vein thrombosis. Compression hosiery encourages patients to be self-caring and to be involved in their care. Patients can remove their stockings on a daily basis, carry out skincare and then reapply. This in turn reduces nursing time and some of the costs associated with managing wounds. But how does compression hosiery work? Here you can see in the infographic that compression hosiery aids venous and lymphatic return. The pressure is greatest at the ankle, reducing throughout the calf and up to the thigh. This graduated compression moves fluid to the root of the limb and promotes healing and reduction of swelling. So how do we select the right compression hosiery? We follow a 3-step approach, and we're going to go through this in more detail. Step 1 is to carry out a full holistic assessment. This assessment should include patients' past medical history, their surgical history, and any medication that they're taking. Calcium channel blockers, as part of a blood pressure medication, can cause edema in some patients. These should be swapped for an alternative or stopped if at all possible. We also need to make a note of any risk factors for venous disease the patient may have. The limbs should be properly assessed, noting any skin changes, any skin or tissue changes, and also this should extend above the knee to examine the thighs and onto the trunk, looking at the hips and buttocks and lower abdomen to see whether there is any edema or skin changes affecting these areas. Psychosocial assessment, finding out how the patient's body image affects them and how their swelling or ulcer or varicose veins make them feel. Often we pay lip service to psychosocial assessment, but setting goals with patients is hugely important, especially in the prevention of further deterioration. We are aware that as part of full holistic assessment, vascular assessment has become synonymous with ankle brachial pressure index. Most people believe that in order to apply compression in the form of bandaging or compression hosiery, that an ABPI is essential. The British Lymphology Society have put together a vascular assessment tool to ease and support your practice to enable you to apply compression in the absence of an ABPI. The British Lymphology Society recognises that it is difficult to obtain ABPI in patients who have pain or swelling around the ankle area, but also that there is a lack of equipment and trained healthcare professionals who can carry out ABPI, which often leads to long waits for patients and inappropriate care. If you would like to download the document, there is a link as part of this Facebook Live, and you can visit www.thebls.com. It is important to take an edema history. This may include how long has the patient had swelling? Does the swelling reduce overnight? Does the swelling extend beyond the leg itself? Are the toes swollen? Is there a normal shape? And are there tissue and skin changes associated with the swelling, including thickening of the skin or papillomatosis, bulging protrusions, often called cobblestones, on the surface of the skin that lead to an irregular surface? Establishing whether or not the patient has edema will assist in ensuring that the patient receives effective and comfortable compression. If compression is not comfortable, patients are very unlikely to wear it. Would you? British standard hosiery is ideal for non-edematous legs. As we've said, it improves venous and lymphatic return, and it can stop legs feeling tired and heavy. British standard compression hosiery in a Class 1 is considered safe to apply to any patient in the absence of ABPI and the absence of any significant arterial risk factors. This is supported by the best practice statement for compression hosiery. European class hosiery is more suitable for patients with swollen or edematous legs. It has a higher static stiffness index, thus it is less elastic than British standard hosiery, and it can be more effective in increasing venous and lymphatic return and aiding the reabsorption of excess fluid. It may be more effective and thus patients are more likely to wear it. Selecting the appropriate hosiery can be very difficult, and the following tools have been designed to support your selection to ensure the correct type and class of hosiery for the patient. First of all, we're going to look at the cross-checker form. This form is designed to help identify skin changes as a result of underlying venous and lymphovenous combination disease. It forms part of the holistic patient assessment, and it gives clear guidance on which compression products can be used to manage the disease type. It's split into 3 sections, which we're now going to look at in more detail. The Hosiery Selector app is available for convenience and accessibility. This helps to measure patients. There are many tips and handy videos you can watch and select hosiery based on patient's condition. This is free to download from the Apple and Android store. The first section on the cross-checker is prevention. This is listed as patients with mild symptoms, and we're going to go through these in more detail. So if patients complain of tired, aching or heavy legs, this should not be ignored. This should be seen as a sign of early onset venous disease or chronic edema, and the patient should move forward to be fitted with compression hosiery. At this stage, there is usually a good limb shape and intact skin. There may be thread veins or spider veins on the surface of the skin, or there may be small veins around the ankle. Mild or moderate skin changes may be present. Hyperkeratosis is a buildup of keratin on the surface of the skin, which looks brown and discoloured. It has large flakes of skin which are often difficult to remove. It may be necessary to use a monofilament debridement pad like Debrisoft, but good skincare and compression can reduce hyperkeratosis effectively. There may be mild or moderate varicose veins, hyperpigmentation or hemosiderin staining on the surface of the skin, like we said, that looks like somebody's been in the sun, and some mild skin irritation or dermatitis. Usually Class 1 compression hosiery will be enough in the absence of edema, British standard, with edema, European class. However, Class 2 compression hosiery should be considered if the symptoms are more moderate. For early or medium intervention, the orange section, where there are moderate symptoms, this talks about fitting patients with Class 2 compression hosiery for mild to moderate symptoms, and again for moderate to severe using Class 3. So let's work through some of the symptoms. Varicose eczema is a skin condition caused by chronic venous insufficiency. There's usually irritation on the surface of the skin. Usually the skin is very irritable and itchy. It can bleed readily and sometimes weep. Atrophy blanche is where there's often been a healed leg ulcer which leaves behind a star-like white scarred area. Induration may be the early onset of lipodermatosclerosis. It's unclear as to whether lipodermatosclerosis is a lymphatic or venous sign, but it is often referred to in textbooks as inverted champagne bottle legs, where there's narrowing at the gaiter area. Moderate or severe varicose veins may be noted. Moderate or severe hyperkeratosis, that build-up of skin. There may be a recurring ulcer or active venous leg ulcer, or even a healed leg ulcer. But again, class 2 or class 3 compression hosiery should be considered. British standard in those patients without edema, and European class in those with edema. Cellulitis. Many patients would remove compression hosiery immediately if they had been previously wearing it and then developed an episode of infection. It is now generally accepted that if patients have unilateral symptoms of infection, a red, hot, swollen leg, with the onset of symptoms being rapid and the patient feeling systemically unwell and requiring antibiotic therapy, that as long as they can tolerate the compression, that their pain levels are acceptable, they could continue in compression hosiery. If patients have not been wearing compression hosiery prior to the development of cellulitis, it is unlikely that they would tolerate a stocking well and may need to wait for the antibiotics to be effective in managing that infection. It is worth noting at this stage, as I stated earlier, that I run the Red Leg Clinic in the UK, and this is for patients with bilateral leg redness. So it is very unusual for cellulitis to be bilateral. In effect, most patients with red legs have red leg syndrome due to another cause. This is usually dermatological in nature, sometimes varicose eczema, sometimes dermatitis, sometimes generalised inflammation from untreated chronic edema. So take home from this, if the legs are both red, hot, inflamed and tender, it is unlikely to be cellulitis, and antibiotics should not be started just in case. The cross-checker goes on to look at advanced symptoms, and today's session is all about prevention, but it's important to know that this is a comprehensive document which takes you through the intensive management of lymphedema, severe hyperkeratosis and other skin changes. The document is available in a link through this Facebook Live and also at the L&R website. So once the correct class and type of hosiery has been selected, it's time to move on to the size and style. The patient can be measured for the correct size of hosiery, which may be in the form of made to measure or off the shelf, dependent on the build of the patient, the shape of the limb, and the cause of the condition. Patients may be able to choose their preferred colour and style, for example, whether the garment has open or closed toe. And the wearer needs information about leg care. This relates to skin care once the garments are removed, washing, drying and moisturising. Also about not wearing the same pair of stockings repeatedly, that stockings need to be washed, dried appropriately and given time to rest, so there should always be 2 pairs provided, one to wash and one to wear. But also to remove the garments immediately if the patient experiences any pain, numbness, tingling, pins and needles, blue toes or shortness of breath. There are many tools and resources to help support the prevention of venous disease progression. L&R has a self-care site which is dedicated to helping patients better cope with venous disease. The Legs Matter website, as previously mentioned, has loads of free resources for you and your patients, and the British Lymphology Society offers further advice on lymphedema and chronic edema. If you are interested in lymphedema, you can become a friend of BLS for free. Visit www.thebls.com. The application and removal of hosiery often causes numerous problems. Many patients will say that they have drawers full of compression hosiery that they don't wear because they can't get it on or get it off independently. There are many really good YouTube videos on the application and removal of compression hosiery and how to do this with certain aids. There are aids for carers to apply hosiery to patients, and there are aids for patients to be independent. If you are unaware of these, the British Lymphology Society has a list on its website, and the best practice statement for compression hosiery has a whole page dedicated to the range of aids that are available on prescription. There are patient information leaflets from the Circulation Foundation and the Lymphedema Support Network and a number of other national patient organisations. So, in summary, Early intervention is the key to preventing venous disease progression and reducing the prevalence of venous leg ulcers. We know that wound care is a huge drain and burden on NHS resources, and it needs addressing, and I'm really hopeful that the sequin will help. Advancing venous disease progression has an impact on patient quality of life. Patient experience is extremely important, as we said, and often patients' experience can be very poor when we have allowed their condition to progress without anyone intervening earlier on. Identification of patients at the early stage of disease can be difficult. We may not encounter patients until they've developed a wound or have significant skin changes, but we all have a responsibility to make every contact count. Selecting the right compression hosiery is crucial for effective management of venous disease. And hopefully there's lots of support to encourage and promote leg health out there. So, what will you do tomorrow in your practice that will drive the prevention of venous disease progression and the prevalence of leg ulcers for your patients and your family and you? We're now going to move on to our real-time question and answer session. Remember, you can take part at any time by commenting on the video. So, let's move on to our first question. Okay, question 1. This is something we get asked all the time. I don't have access to a Doppler. What can I do in the meantime to assess patients and get them into hosiery if they are at risk? So it's really common for patients to get healthcare professionals to get in touch with us and say they don't have access to a Doppler. There's a waiting list for Doppler for patients having to wait to go to tissue viability or other services that can provide an ABPI. So hopefully you've taken on board that the British Lymphology Society, so they have a free to download vascular assessment tool which you can use to guide your practice so that you can fit patients safely with compression hosiery without an ABPI or without a Doppler, as long as you are assessing their risk factors for arterial disease. The document takes you through a tool, which means that you don't miss anything, and it also helps you to understand what may be happening to patients if they have got signs of arterial disease and how to move them on to get help. There's also a letter in there, which is a standardised letter to send to healthcare professionals involved in the patient's care so that you can explain why you fitted with compression hosiery in the absence of an ABPI. So don't wait, get patients into compression at an early stage, and hopefully we've provided you with some tools to do so. I hope that helps. So, question 2. My patient has a leg ulcer. I thought you always had to use a compression bandage if you have a leg ulcer. Is this correct? No. In a simple answer, as long as the patient has a reasonable shape to their leg, as long as they don't have a heavily exuding wound, and as long as their measurements fit within the remit of a leg ulcer hosiery kit, that would be our front line. For patients who have significant oedema, a very leaky wound or a poor shape, we would move forward to use compression bandaging in the first instance. But leg ulcer hosiery kits mean that patients are in control of their care. They can take ownership to provide their own skincare, which is on a daily basis then, rather than once or twice a week if they're relying on only carrying out skincare when they have a bandage change. So in answer to your question, you don't always have to use a bandage if the patient has a leg ulcer. So Christian Borland has sent in our next question saying, why do venous leg ulcers take a long time to heal? And besides the patient's nutritional state, would mobility impact on leg ulcer recovery? Well, this is a very interesting statement. We've talked about how we remove blood and fluid from the leg by getting patients to increase their muscle pump and activity. So yes, you're already thinking along the lines that we do need to be encouraging patients to be as mobile as possible. But with increasing age and comorbidity, we know that that's not always possible. Nutritional state is very important. But actually what we know is that many patients do not improve with their leg ulcer to healing because they do not have the correct level of compression applied in a timely fashion. And this is often due to the Doppler not being available, that ABPI. And also, patients are rarely referred to vascular services so that they can be assessed to see whether they're suitable for endovenous ablation or for surgical intervention, which may actually improve their situation. So it's about wound assessment, it's about following your times or whichever assessment you're using and making sure that you are doing everything possible. And again, I really hope that the leg ulceration sequin will help to move patients forward and improve and speed up leg ulcer healing. So thank you, Christian. So question 4 from Liberty says, can I wear compression hosiery as I'm a nurse who is on the go all the time while working? Yes, Liberty, you can. We wear compression hosiery in the lymphedema service every day. It's fantastic for reducing the aching and heaviness that your legs feel towards the end of the day. And you as a nurse are a prime candidate, unfortunately, to be one of the patients of the future if you don't do something early. Also, you'll be a fantastic advocate for your patients. If you're able to show them your compression hosiery and show how easy it is to use and how comfortable it is, then they'll be much more likely to wear theirs. So yes, you can wear compression hosiery and look into getting a prescription for yourself. So the next question from Lisa Shepherd is, how do we deal with patients with an inability to wash their legs and feet daily and apply hosiery? This is something that classically comes up all of the time. It's extremely difficult when patients are not able to reach their legs and feet for whatever reason to carry out skincare and to apply and remove compression hosiery. There are numerous patients that don't have any carers, they don't have anyone to help them. So this is about us trying to do as much as we can in a far from ideal situation. Patients are resourceful. Sometimes we've been able to utilise long-handled sponges to enable patients to wash their legs and feet. Sometimes if the legs are swollen, it's difficult to fit into a bucket or a bath, so using wipes is easier. And also applying cream is hard, but there are spray emollients. So sometimes it's possible to encourage independence with moisturising using a spray emollient. The application and removal of hosiery is a different issue. We've talked in the session about some of the aids that are available, but there are compression hosiery alternatives now. We can have stockings made with zips or with Velcro fastening, which can mean that many more patients, especially those with dexterity issues, can apply and remove their hosiery independently. Or if they need assistance, then this makes for a very easy job for a carer. So it's about individualising care, it's about assessing properly a patient's ability to manage and recognising that we're not always going to be successful in having a perfect outcome, but if there are ways that we can deal with cheating to get legs washed and spray moisturised and then an easy way of applying and removing hosiery, then we're halfway to dealing with those hard to reach patients. So thank you for your question, Lisa. So Amy Hughes has asked, if a patient's leg becomes swollen at the top of the leg once they've been in hosiery for a few weeks, does this mean a bigger size of hosiery is required? Okay, so there's quite a number of reasons that this might be the case. I'm presuming that we're talking about a patient who's wearing below knee compression hosiery and then the swelling has extended into the knee and above the knee into the thigh. It may well be that this patient had swelling throughout the whole leg, and on assessment, the whole leg was not assessed, only below the knee was measured and assessed. So the patient was fitted with a below knee stocking when a thigh length stocking would have been more appropriate. Thus, the below knee stocking has moved fluid into the knee and thigh. So in this instance, a thigh length compression hosiery garment, well measured and fitted with a hold up in the form of a grip top or thigh with a waist attachment would be ideal. Unilateral leg swelling, however, may indicate that there was an underlying problem. So it's necessary to do a full assessment to see whether there could perhaps be any acute cause for that increase in swelling. Could there be a possibility of a deep vein thrombosis? Could there be some impairment to drainage? So it is important to look into anything that's unilateral. However, it's likely that below-knee hosiery was used where a thigh-length stocking would have been more appropriate. And if necessary, then bigger sizing for a short period until the swelling is better controlled. Thank you, Amy. So Nikki Millen has asked the age-old question, which is so important to raise, so thank you, Nikki, regarding how do you deal with non-compliance? I think there's a huge discussion around the terminology we use. Do we use non-compliance? Do we use the term concordance? Do we use patient's wishes, patient's experience? I think in the world of lymphedema, we are well placed to look at patients who don't want to wear compression, don't want to engage with compression hosiery and compression bandaging, because often when they reach a lymphedema service, they've had a poor previous experience with compression. They've got a drawer full of stockings that they haven't worn, that were uncomfortable, that were prescribed by their GP, that wasn't measured or fitted. They may have had bandaging which they had to cut off or found very uncomfortable. So it can be that we're ideally placed to start up a new agreement between the patient and ourselves to look at the best way of improving their symptoms. Patients often want their symptoms relieved, their pain reduced, their heaviness, their aching improved, and sometimes it's about dealing with each individual bit that bothers them the most, even if that's not what bothers us. So we might want to move a patient very quickly forward to an effective level of compression, and actually we might need to start off with something that's a little bit more gentle and a little bit easier, and then build up from there. However, that's no excuse for reduced compression for an extended period of time. Most patients just want to improve their symptoms, and if we can work with them to do so, that can be really important. Patients who've tried compression hosiery, who have varicose veins which are symptomatic and have never seen a vascular surgeon to see whether there's any intervention that could be suitable for them, should move forward with new, well-fitting compression hosiery to that vascular assessment. They will feel surgical assessment. They will feel that you have bought into their problem and hopefully feel that you really care to make a difference. Compression lends itself to any patient, any size, any shape. It's just about your experience with making sure that you choose the right garment for the right patient. And using some of the tools we've talked about today, like the cross-checker and the app, may help you to do so. So Aria Christina has asked, for mild venous leg disease, can we advise patients to buy standard hosiery from medical shops? This is very interesting. There is a move towards less prescribing, for example, of emollients and for silk undergarments, and often patients have to self-fund these items. For mild venous leg disease, in patients who have early onset varicose veins, those of us that are at work like Liberty asking whether she should wear her stockings, yes, we can buy standard hosiery from medical shops. Sometimes you can buy online directly from companies like L&R. However, patients who are trialling compression hosiery for the first time may find it difficult to buy their own hosiery, to measure and fit a garment appropriately. This should be done by a healthcare professional, and garments are available on prescription because they are a medical device. So often we can support patients to buy more pairs of hosiery once they've been appropriately measured and fitted. So I hope that helps, Aria. Sarah Jetton has asked, if I have an arterial ulcer, can class 1 stockings be used? This is very interesting, Sarah, because arterial ulcers are not my area of expertise, being a lymphedema advanced nurse practitioner. So if this was a genuine arterial ulcer using my wound assessment, then I would be moving that patient on to an appropriate healthcare professional. So using class 1 stockings for this patient would not be my choice. I would definitely be moving them forward to see a specialist. That might be you, Sarah. And Shelley Walters has asked a very important question. Why has an ulcer returned when wearing compression stockings? This is very interesting because this seems to be a common occurrence. And when we talk to patients, it actually turns out that they weren't wearing their compression hosiery. They'd thought that because the ulcer had been healed for some time, they no longer required it. So that's the first thing to find out. Maybe they've been prescribed them and they've got them, but are they actually wearing them? The other thing is about, have they got the correct level of compression within those stockings? So often patients have 40 millimeters of mercury in their therapeutic bandaging to heal their leg ulcer. And then once compression hosiery is started, it's 20 millimeters of mercury. So it's half of what they were wearing in their bandages to heal their ulcer. So often the compression is not significant enough to prevent that ulcer returning. So that's the first thing to check. Excuse me. So moving on to our final question of the evening, Lisa Williams has asked, how do you provide 60 millimeters of mercury compression for taller patients? So if we relate this to compression hosiery and we're looking to provide high levels of compression for taller patients, there are hosiery companies that provide compressive wraps, so Velcro wraps which are easy to apply and remove, which have high levels of compression. There are also made-to-measure compression stockings, which are class 4 European class, which are 60 millimeters of mercury at the ankle, but also you can double layer garments where necessary. Sometimes this can be very beneficial in patients because wearing 2 garments which are lesser strength can actually be easier to apply and remove. So there are a number of ways, but never forget that in taller patients you'll need to use a long option. So most stockings come in a regular or a long length. Some of them offer short, some extra short, but certainly in our taller patients where we're needing those higher levels of compression, we would need to select the longer length option. So this concludes our live training session. Thank you so much for watching and for submitting your questions, which were excellent, and I really hope you found it useful. I'd like to take this opportunity to thank L&R for their support of this event. And in order to access your certificate of attendance, visit the link shown on the screen now, or alternatively, it will be pinned in the comments section. In 5 weeks' time, Wound Care Today 2020 will be taking place in Milton Keynes. Wound Care Today is a free event offering delegates the latest in clinical education along with personal development sessions, practical learning zones and the opportunity to network with our friendly community. For the full programme and for booking details, visit the Wound Care Today website. The British Lymphology Society will be there, will you? I hope you've enjoyed the event today and have gained a better understanding of venous disease and how we can prevent progression. Like the Wound Care Today Facebook page to hear first about our future events. And thank you very much. Goodbye.